come to the dais. Dr. Varsha from NIV Pune to please. Dr. Shanta Datta, Director NICD, to please come to the dais. Dr. Catherine Tan, Asia Lead for CDC. Dr. Lalit Dhar, HOD and Professor Microbiology, AIIMS, New Delhi. And Dr. Anand Krishnan, Professor Community Medicine, AIIMS, New Delhi. I would request Dr. Lalit to give his welcome remarks for all the participants and dignitaries.
I wish you a very good morning. DG and Secretary, DG ICMR and Secretary, Department of Health Research, Dr. Rajiv Behel, Dr. Catherine Tan from CDC USA, other faculty on the dais, and our veteran in respiratory viral research, Dr. Mandeep Chadda. All our friends from the collaborating institutions in this project, from NICED, from NIE, from NIV, and other friends and colleagues. I'm very happy to welcome you today to this activity, which is essentially showcasing the work that has been done under the aegis of CDC India and CDC USA on influenza virus, especially in the elderly population in this particular project. We have a long-standing collaboration at AIIMS through a cooperative agreement with CDC in this area, in influenza viruses and respiratory research, and it has yielded a huge amount of information on disease burden specifically, apart from vaccine-related research in addition to that, and also on other respiratory viruses, including RSV and other viruses during the course of this time. The initial seeds for this were planted by ICMR in the around 2005, 2006, when the first project started for surveillance. And happily, ICMR is still pursuing this surveillance activity and sustaining it across the VRDL network. And so we are very happy to have all the key players, some of whom we have been associated for the last more than 20 years with us today. And I would like to thank all of you for sparing your time for this. And let us hope that we are able to project whatever work we have done in the past few years, and so that it can be disseminated for policy making. I think the ultimate aim of any public health research is that it gets translated into policy, and the elderly do suffer from the sequelae of influenza as well as the virus itself. So I think that is why this is an important activity. So welcome all, and I hope we have a very productive day today. Thank you.
Thank you, sir. I welcome Dr. Anand to disseminate the findings of this 5-year project.
Thank you, Madhusri. So my presentation is on behalf of the INSPIRE team, and the team is well represented here. It's my privilege to present the findings of this collaboration, and it's very appropriate that DG ICMR is here as our guest to listen to this. Also because, as just now Lalit said, it has policy implications. So this previous COAG was focused on the elderly, especially influenza among the elderly, trying to assess the burden. Just a disclaimer that these are the final results might be slightly different once we clean up everything. But I think it will be happy to hear from all of you, including the panel which follows this, which will give us a direction on how to move further with these findings. And we will definitely be publishing it subsequently. And So this network comprised of 4 sites, Delhi, NIV Pune, National Institute of Epidemiology Chennai, and NICET Kolkata, with 2 broad areas, one which looked at the community part of it. All 4 of us adopted the community and looked at a community cohort to look at incidence of influenza, the cost of influenza, and its impact on frailty, and we subsequently added some COVID-related questions to this cohort because it was like all cohorts, it's a very good resource to have. And we also had a hospital component which looked at positivity among the hospitalized patients, elderly patients, what is the outcomes and the cost of treatment. So we started in July 2018 and continued till May 23 with some interruptions due to COVID. In the community component, we had enrolled the cohorts, followed them up after consent. A weekly surveillance was done on respiratory symptoms, cough, fever. And those positives we took a swab and they were tested for the lab. And also we looked at their healthcare seeking and cost of this each episode of respiratory infection. As you can see, this gives you the numbers. You can see the numbers are huge. We had almost 7,000 participants across these years, with you can see almost 24,000, almost 25,000 person years of follow-up. So it's a huge amount of work done by all of us, the team. Obviously, we had some interruptions in the between April to September 2022 because of the restrictions. If you look at the hospital component, again, we identified 4 hospitals in each site: public, private, tertiary, secondary. Any patient satisfying SARI criteria above 60 years was again tested and followed up till discharge and till 30 days of discharge. So we enrolled about 1100 pneumonia patients across these sites. This component finished in March 2020. Once there was a break, we didn't continue with this component. In terms of, we also looked at COVID management, but not too much on this aspect. So we looked at how many got admitted to ICU, how many died, and you can see some numbers there, and I will come back to those numbers. One of the issues was that definitely in Kolkata there was very high ICU rates and discharge, but that's compared to the other sites. So we look at some key results before I go to this. You can see that we have large number of AURI and ALRI cases being enrolled during this process. Influenza positivity in AURI was around 2% to 4%, and in ALRI was about 8% across the sites. We also followed them for deaths and looked at what was the cause of death. All deaths had verbal autopsy done and cause of death ascertained. So this is the respiratory deaths. As you can see, we had sufficient numbers during the early period, pre-COVID period, as well as post-COVID period. In the hospital component, again, you can see that the ICU hospitality rates are very high, especially in Kolkata, and 30-day mortality was very high. But influenza positivity, as you can see, still is about from 10% to 17% across the sites. So that was our base for which what I'm going to talk subsequently. So then we moved, based on this, can we estimate the burden of influenza in the country based on these 4 sites? We used 3 years data. We dropped 2020 because of the COVID restrictions. So we have full year data for 2019, 2021, 2022. So adjust for seasonalities. Again, you can look at the flu positivity rates across the site. You can see 20 to 22 was a bit, has lesser percentage, about 2% and 6% across AUR, ALR, whereas others it was slightly higher. Site-wise also there were a lot of differences. You saw some of them in the previously. So we feel that this captures the variations in influenza epidemiology geographically as well as across the years. We stratified the population of India into 2 groups, 60 to 70, 70 plus, male, female, and all estimates were prepared for these 4 subgroups before combining them to generate a national estimate. And we use a meta-analysis approach. So we had 4 sites and 3 years. So this was treated as 12 studies. And we use those 12 studies and use meta-analysis to combine the estimate for the country. So this tells you the key findings after this. The overall, you can see that it says that approximately each elderly has about 4 episodes of ARI a year. Obviously, almost bulk of it is the about 3.5 is the AURI, but at least about 1/5 of them result in a pneumonia or ALRI, and another about 1/4 of them result in a severe ALRI. And severe ALRI we defined as anybody with a respiratory rate of more than 30 or SpO2 less than 94%, or they were hospitalized because of this condition, or they died with a cause which was attributed to a respiratory cause. And we applied influenza positivity among them, so get an influenza-related hospitalization. The influenza positivity among inpatients and among deaths came from the hospital component, whereas the influenza positivity among AURI and ALRI came from the community component. So based on this, we build the pyramids. So you can see we estimate about 6 million episodes of influenza to be occurring in this age group nationally, 4.8 being AURI, but more importantly about 270,000 cases which had severe ALRI, and 84,000 died because of this, with the range of 40 to 155, using the census India estimation population for 2020. If you look at these estimates, are they credible? We looked at the past. We have also in the past estimated respiratory mortality due to flu using an excess death approach. And this matches reasonably closer with that. That was for almost 10 years back. If you look for population growth, and that was for 65 plus, and this is for 60 plus, this would be very close to each other. Even severe ALRI incidence that we found matches with the other studies in this region of the world, about 200 per 100,000, or about, you can say 2 per 1,000. Based on this, then we applied healthcare utilization data from our own sites, which includes the community component provided how many attended OPDs and how many went to were inpatient, and within the inpatients how many were admitted in the ICU comes from the hospital component. So again, taking both of them, these are the numbers. So we have about 47,000 respiratory hospitalization in this group, and 22,000 needing ICU, and about 10,000 people dying. We compare this with 84,000 that we estimated as total deaths. So it just means that only 1 in 8 deaths occurs in the hospital. Rest of the cases die at home. They don't seek care. So that's an area that we will pick up later on, that many of these deaths occur outside the hospital. Again, if you look at the hospitalization rates among elderly with respiration from NSSO, it matches what we are saying. And our earlier estimates for hospitalization also are in the same range as this one. So we believe that the results provided by these estimates are very credible and match both with earlier national, other national as well as international estimates. Again, using the cost data from our study at both community and hospital component, which looked at inpatient and ICU costs, applying those costs, which is also shown there. For example, in ICU, one episode cost about 1,07,000, and inpatient about 33,000. So if you apply these costs to the numbers that I gave in the previous pyramid, you will get this pyramid, which is on the in the amount of money, cost of the illness. Total is about 13 or 14 billion rupees. 25% is direct cost, and this is approximately 0.2% of the total health expenditure that is estimated for India. Now going to the cost effectiveness analysis using a decision tree approach and a societal perspective. Since vaccine is given annually, our study horizon is 1 year, and we are comparing no influenza vaccination, which is the current status, versus if we start an annual influenza vaccination, either using a passive mode, which is a facility-based mode, or an outreach mode, which means a session, that you have a field session to give this vaccination, using quadrivalent annual intravascular vaccination. And we estimated the cost per daily averted. So just this is the decision tree that we used. The probabilities that you see in this decision tree have come from the study. The shaded areas have come from the hospital component. The unshaded areas have come from the community component. So we could estimate all these probabilities through this study, which enabled us to do this analysis. So incidences that you see, these are part of, as I've already covered many of them in my previous part, about the annual incidence of influenza, proportion of seeking care, probability of mortality, and proportion needing ICU. We applied the median age of death in this cohort was 69.5 years, so we used that to estimate years of life lost. and based on the duration of illness for all the different 4 levels of sickness, mild, moderate, severe, and ICU admission. Using disability weights with GBD uses, we converted them and calculated the DALYs. Again, cost data we have seen. The cost of vaccine we took from what is given in AIMS rate contract. The cost of delivering vaccine comes from earlier studies on immunization program, not obviously on adult immunization program. But we feel the delivery will not be very different cost of delivery, whether it is an adult vaccine or a child vaccine. We assume 2 coverages. If we do a facility-based coverages, we assume 30% coverage. This is because when we offered vaccine to our cohort, only 30% accepted the vaccine. So that is the minimum that we expect. Whereas if we have a more outreach, we think it might go up to 50%. Again, this is just an assumption. So based on that, if you look at the numbers, the total 13.6 billion we saw earlier in the pyramid. If you give a passive program, your number comes down to 11.6 billion, and outreach program is 10.3 billion. We also looked at a scenario of 65 plus because currently in the government national guidelines, people with comorbidities are allowed, are recommended for vaccination, whereas elderly are only in desirable group. We saw our data showed that above 65 plus, almost everybody will have a comorbidity. Having a comorbidity as a classification, we know India, many people don't get diagnosed. So we feel rather than using comorbidities as a criteria for vaccination, if we use an higher age cutoff, automatically bulk of them will have a comorbidity. It will be operationally much more easier. So we also looked at a scenario where if we, instead of vaccinating 60 plus, we only vaccinate 65 plus, what happens to the cost effectiveness? So these are our results. Again, you can see that obviously as you go from passive to outreach, the number of vaccinated increases, but it goes down because number of eligibles become less in 65 plus. DALYs averted, again you can see, obviously the highest DALY averted is in the outreach program because you are covering more people with a higher coverage. But if you look at incremental cost of DALY averted, cost effectiveness ratio, you can see the numbers, it is about 155,000. Often in cost effectiveness analysis, we use per capita national GDP, which is 145,000 for India, as a cutoff for saying whether a intervention is cost effective or below. If that ratio is less than 1, it is supposed to be very cost effective. If it is ratios between 1 and 3, it is supposed to be cost effective. So as you can see, this falls on the cusp of 1, and especially if you go to 65 plus, it might be very cost effective as well. So overall, from the data that we have generated from the INSPIRE study, makes a case for influenza vaccination of elderly as it is cost effective, and definitely a much stronger case for vaccinating people above 65 plus with the vaccination. So some points to consider before we, currently the vaccination coverage which surveys show, it's almost negligible. Second, there is enough evidence to show we have not taken into account whether influenza vaccination has a disease modifying effect. It only, we are just preventing mortality and hospitalization, but not really disease attenuation. Nor are we looked at cardiovascular outcomes, like there have been evidence to show that influenza also results in increased risk for cardiovascular outcomes. Or it prevents antibiotic use because less people develop pneumonia, you use less antibiotics, it has implications in terms of AMR. On the other side, we have also not included side effects of management of influenza. And we know vaccine effectiveness varies widely even from year to year. And starting a new program, vaccination program, has its programmatic implications. But obviously we know the bulk of the program cost will come from vaccine, and vaccine cost is a negotiable cost in depending upon the bulk of the order. So as a group, the INSPIRE team believes that this current guidance, which is saying that vaccine is only desirable for elderly individuals, needs a rethought. But without too much change, because currently it recommends persons with chronic illnesses. Our data shows that combining these two and making it a vaccination program for all elderly above 65 years of age as to be recommended makes a policy sense to us. But obviously this needs to be much more debated and evidence critically reviewed before we come to that. So that's all. We will have a good panel discussion subsequently to debate on many of the issues that this presentation has raised. But I'm told Dr. Rajiv Bahl is pressed for time. He has a commitment. So now I request Dr. Rajiv Bahl, he has heard us. Maybe he can give his quick comments on what his thoughts are on this issue. Thank you, please.
Thank you very much, Dr. Anand. And my apologies for pressing you all to change your schedule. And unfortunately, the President of India is launching Ayushman Bhava campaign today. And so we are all have to attend that session. It's a health ministry initiative. First of all, I'd like to congratulate the Inspire team. And thank you very much for doing this wonderful job. And also thank CDC and the ICMR institutes. I can see you have actually 3 of the 4 sites are ICMR institutes. So very happy to see NIE, NIV, NICED. These are some of our best institutes of ICMR, and it's a very important issue. And as you said, we have this pan-respiratory viral surveillance now across the country in all the virus diagnostic research labs, which have also grown in number to beyond 150 now, where we are looking at not only influenza, COVID, but now also RSV in the same patient. So all the patients are looking at that, and we that is one good thing, as you said, which started with this initially, this initiative. Flu, influenza, I mean, there is no doubt in our mind, in anybody's mind, that it has the potential to be a pandemic at any point in time. It is one of the most important viruses that we have to keep a watch on. There is no question on that. And in fact, the surprise was we got a coronavirus pandemic, but that is something that we still cannot rule out whether the next, what will happen to influenza, given how quickly it mutates. Now, in terms of vaccination, and so these data are very good, and evidence is always welcome, and evidence should be used to move forward as we decide policy. But just to add one quick thing, you must all be you will be happy to hear what I'm going to say. In fact, this morning I approved the file where we are going to issue an expression of interest of a implementation research study in multiple districts in India, where we will actually implement vaccination as a implementation research project with all the outcomes that you mentioned: mortality, morbidity, but also antibiotic use in terms of its contribution to resistance. We are also will consider pneumococcal vaccine in addition to flu vaccine. So that study is part of what we are calling the National Health Priority Research Program. And we are going to invest funds into at least having a few districts do that across the country. And depends upon the budgets and all, and what we will be able to afford, how many districts we can take. But my goal is to take 1% of India as my benchmark, which is 7 to 8 districts for these mega projects. So in effect, already that will provide even further evidence, and also not just evidence that of whether it is effective or not, but also learning how to do it in the best possible way by actually doing it on the ground, so that then can guide further policy. So these data, of course, will be very beneficial in planning that research, and then finally the policy. So very happy to see these data uh, and very timely. So as said, serendipity, I just cleared the file at come at 8:30. First was looking at those files, say, okay, this one is here. So by tomorrow you should see it, or in 2 days you should see it advertised as a as a priority project. So in principle, I have no disagreement that this is a very, looks like a very useful intervention in terms of a little. I was actually thinking that it might cause more deaths than 84,000, but that's the number. So that's the number per year. But the financial aspects are also quite impressive, and I hope that it will also have substantial reduction given if we don't have episodes in antibiotic use. We are thinking about 4 episodes per person per year, and it means a very large antibiotic use. So I don't have much more to say except thanking you all, and my apologies again for not being here for the entire panel discussion. But thank you and wishing you all the best for your discussions and putting it all together. Thank you.
Release the. I request all of you to join. Problem with Dr. Bed, please come join us here. Okay, thank you.
Thank you.
Okay, thank you very much.
Thank you so much.
I now request Dr. Catherine Tan, Asia Team Lead, CDC Atlanta, to give her remarks on influenza vaccination among elderly.
Good morning, everyone. It's an honor to be here today to say a few words before we get into the discussion of the findings of the INSPIRE study. This dissemination meeting really marks a milestone of a long, fruitful CDC-AIMS collaboration over the years. And the findings of this INSPIRE study is important not just for India, but also globally on influenza burden in the elderly. As we know, it's not well studied, and the elderly population is growing, especially in low to middle income countries. And through the hard work of India as well as other countries, using improving healthcare systems and use of public health tools such as such as vaccinations, the growth of this population means the growth of a vulnerable population. And so, as was brought up by Dr. Lalit and in his talk, this population is vulnerable to not only getting influenza, but also having poor outcomes. And the influenza vaccine can reduce the risk of getting influenza and is disease modifying in that it can reduce severe disease and hospitalizations. And I'll just give an example from the US where we do vaccinate the elderly in the 2019 to 2020 influenza season. This is right before COVID. We found that through influenza vaccination, we prevented 390,000 hospitalizations and averted about 25,000 deaths. And so as we think about the potential impact of the influenza vaccine to India, we can look at the INSPIRE's data that will give us an idea of how impactful this vaccination could be. And as we look at numbers such as death, for example, we have to also think about frailty, which is the other finding of this INSPIRE study, as frailty and increasing frailty can also predispose the elderly to death. And so I'm confident that INSPIRE will be helpful in informing influenza vaccine policy in India globally. I was very, very excited to hear from Dr. Rajiv Bal, this new initiative, this National Health Priority Research Program to do implementation research in some of the districts here. As we know, we can do what we can to do research to develop the evidence to support policy change, but the implementation, the real life rolling out of these interventions is the other piece of the puzzle. So it's very, very exciting news. And so I will just close with congratulations on this really important, impactful work by the INSPIRE's team. As we all know, this is the culmination of the hard work of many hands over many years. And so I thank you and look forward to the discussion this morning.
Thank you so much, Dr. Catherine. I would now request Dr. Anand to give out mementos to the INSPIRE team.
More distinguished people here. I think we can ask others to gain focus.
Requesting Dr. Shanta Datta to come, please. Dr. Dr. Suman, sir, please. Dr. Alok, Dr. Krishna, I request Dr. Girish, NI, Dr. Prabhu, Dr. Mohan Raj, Dr. Bhanupriya, requesting Dr. Varsha from NIV, Pune. Dr. Sumit, request Dr. Siddharth from CDC India. Dr. Aslesh, Dr. Venkatesh, Dr. Deepika, request Dr. Catherine to please come forward. Dr. Archana, AIMS team Dr. Ashish, Dr. Vizihol, Dr. Shivram, requesting Dr. Rakesh and Dr. Girdhar to come, please. Dr. Asad, Prerna, Dr. Mansi, group photograph and group. Someone to please come and give a vote of thanks. Sir.
Good morning, everybody. The first part of the program, it's a very important program, has come to an end. So nothing comes in, it's a beginning, a new beginning. Now I have the responsibility of providing you a vote of thanks. So it's a heartfelt, it's a fantastic journey for the last 5 years that we all had across India. So with the start, I must thank the Central US CDC as well as CDC India. In CDC India, led by Dr. Siddhartha Shaha and US from Dr. Catherine Tan. Thank you very much for providing all the supports. And all these sites who have relentlessly worked towards to attain this goal under the aegis leadership of Professor Anand Krishnan. So I'll come to him later at the last, but it's a fan. He led the whole team so brilliantly, keeping each and everything in place. And thanks to the central coordinating team, All India Institute of Medical Sciences, New Delhi, who not only conceptualized the project and took all the partners on board, and it's a joint effort that we all did this study together, and it got very meaningful findings, as Dr. Rajiv Behl has, our DG has said, that it has got the evidences are pretty robust, looks very robust, and for the first time it could have some meaningful policy translation in future. And to name a few names, basically, one person I should name, that is Dr. Kritik Amarchat. Ritik, oh, okay, fine. Thank you very much. This is from all of us, that you cemented the whole team together. And at the same time, may I take the opportunity to thank all the institutional heads, the administrative heads, the administrative support. Not only we get the administrative supports, but I can express from my institute, we had the feedback, technical feedback from the institute heads, the directors also, from NIE, NIV, and from my institute, Dr. Shantadatta has come. Actually, they provided us very minute feedbacks, and whatever we have asked for, because it's a community study, whatever we asked for, I mean field study, whenever we got full support. That's a thank you, ma'am. Thank you for all your supports. And at the same time, the administrative as well as the technical supports from this All India Institute of Medical Sciences team, the backup teams that we had from the data management, from the laboratory. Thank you very much for the laboratory as well as data management team. And at the last, I must thank all the dignitaries and delegates who have come, Professor Kaul, Dr. Vivita Gupta, Professor Chanda, that we have all come to have a meaningful discussion about the findings. I hope this will grow further, and it will have some meaningful ending. It's not the end, it's the beginning. Thank you very much. Again, thank you, heartfelt thanks from all of us. Thank you.
Thank you so much, sir. So we'll have a group photograph now with both the Inspire and the Inspires team. So, Chair.
I request all the Inspire team first to come. Please come. Huh? Ajay, please. We can.
definitely responsible for.
Who's the current director of the Sher Kashmir Institute of Medical Sciences, a renowned researcher, pulmonologist, and with 350 publications to his credit, and going strong. He has immense contribution on research on influenza epidemiology. He has always been part of the NIV network, and his research, immense contribution to the research of vaccine uptake among priority population also. He is the chief editor of the flagship journal Lung and is a member of the National Technical Advisory Group on Immunization. Welcome, Dr. Kaul. Next, I would like to invite Dr. Siddharth Saha. Dr. Siddharth is the director of CDC Influenza Program for South Asia. He has 10 years of experience in collaborating with premier institutes in India for conducting of influenza research and surveillance in the country. He has numerous publications on epidemiology of influenza in collaboration with premier institutes in the country. Welcome, Siddharth.
My pleasure to invite Dr. Indrani Gupta to the panel. So she is the professor and head of Health Policy Research Unit at Institute of Economic Growth, Delhi. She was also the member of Governing Board of Health System Resource Center and member of National Technical Advisory Group on Immunization. Her area is health insurance, health financing, health economics, cost effectiveness, and you can really appreciate why she is there in the panel, because that's one of the areas that we would focus on today in the panel discussion.
Last but not the least, I invite Dr. Nivedita Gupta. Dr. Gupta is a scientist F and head of epidemiology and communicable disease division at the ICMR. She's been instrumental in scaling up the testing capacity for COVID-19, setting up virus research and diagnostic laboratories, and designing treatment and testing protocols in India. She looks after the VRDL network of laboratories in the country, which conduct pan-India surveillance for viral etiology of ILI and SARI cases. Welcome, Nivedita.
What I had to present on the meeting of our findings. So we will start with comments from Dr. Mandeep Chadha and then proceed to the panel.
So thank you, Dr. Anand. Actually, at the outset, let me thank Dr. Anand and his team and the entire Inspired team for having me here. It gives me immense pleasure. We've heard such a fantastic presentation from Dr. Anand, and there are several things that have been really, really brilliant. But there are a few points that I would like to make, actually. So as DG said that he expected the deaths to be much more. So here, obviously, this is a model that they have created, perhaps. And but yes, we really need to do a lot more as far as hospitalizations are concerned. We know that our elderly are usually their health is not priority for them or for the people taking care of them. So that aspect which is a societal aspect also we need to take care of, and ensure that there is better access to healthcare for the elderly. They are our treasure. They should be taken care of very well. Another aspect which I would like to touch upon is that we are already doing surveillance. Nivedita will obviously tell us more about it. But then the importance of surveillance cannot be overemphasized. Over last 10 years, surveillance has been going out. And look at the fantastic data that has come out of overall surveillance. There are so many publications. We've talked with collaboration with CDC. We've had projects where we've talked about seasonality, we've talked about the strains, we have contributed to the vaccination process by providing our strains to the collaborating centers. So surveillance has to continue, and the more the better. So that is another aspect. As far as vaccine is concerned, there are several issues as far as, first of all, there is a vaccine hesitancy, and among the elderly it is more so. There may be various causes, maybe they are structural causes, demographic causes, but most of all, I think in our countries, there is a publication which is little old, but the 6 countries were looked into. 3 of them were from South America and 3 were from Asia. The Asian ones were Thailand, Indonesia, and India. So in this study, it was shown that basically the hesitancy was mostly because of the cost of the vaccine. And once some of the countries, like Thailand, provided it free, so their uptake was much better. And in Southern America, Chile later on started giving it for free, and the uptake was much improved. So this is an aspect. And another important paper that just in MMR has shown the effectiveness, vaccine effectiveness, wherein 40% of reduction of hospitalizations took place due to severe acute lower respiratory infections. So it is obviously necessary. And looking at the data Dr. Anand showed, I don't think there's a doubt in anybody's mind that elderly should be vaccinated. But here again, there is a question. Which vaccine do we give the elderly? We know that their immune systems are weakened. So we need to give vaccines which are either have adjuvants or a higher dose. So that aspect also in our nation, for ourselves, we need to look at. And perhaps some studies to that effect need to be done. And of course, global aspects, Siddharth will take care of, so I will not talk about them. These are the few points that I would have liked to raise. And the last one, which I happen to forget, is vaccine advocacy, because uptake of vaccine is so poor in our country, even when it is free. Because we have seen the example of Maharashtra state where vaccine was provided free to pregnant women, but there was tremendous hesitancy for whatever reasons it may be. So advocacy also is a very important issue. That's what I would like to say. Thank you so much.
Thank you, ma'am, for your, I think, very insightful comments. Now we move to the panel, the esteemed panel we have. They have gone through the presentations and heard me. I think before this is largely meeting focusing on vaccination, but I think one issue that troubles me is that bulk of the deaths occur in the home. There is a serious issue of lack of access to elderly. This is obviously not an influenza specific issue, it's a generic issue for pneumonia. If you want to prevent influenza deaths, obviously one is to prevent the infection, but also another way to prevent deaths is to increase access to care. So this is my question to Dr. Dev. Sir, how do you see, how can we improve access to healthcare to elderly people, especially now the country is going towards the health and wellness centers, there are new cadre there. So within the primary healthcare context, currently NPHSC only looks at facility-based care, and that's obviously not sufficient. So how do you see this progressing on improving access to care to the elderly?
About 3 decades back, my academic career started with infectious disease research, and my first funded project from ICMR was on atypical infection in older people. So obviously, getting older people admitted in hospital with respiratory infection has got a few challenges. I look at them from 3 points of view: biological, social, and institutional. Unlike young adults, pneumonia in older people is not a very acute, very dramatic event. In young adults, as we studied in our pathology classes, red hepatization, gray hepatization, high-grade fever, one can point out that the disease started at this point of time. In older people, it's a kind of some khasi jukham leading on to bit of a cough and cold, and then that gets prolonged and the general deterioration in health. So for the older person to make a decision that I am not good enough to be at home and go to hospital, family getting convinced that things are rather bad, should go to hospital to a doctor, is a very critical decision. It occurs in many other health situations like heart attack, like stroke, a similar situation that I am sick and I should be seeking health care. And then use of antibiotics are so common in our society that probably family will think, let's give some antibiotic and then we'll see later that what's happening. So this is kind of a biological issue, that the disease is not very acute and rather insidious. And then comes the institutional problem. If after kind of surpassing all these hesitation, when older person reaches an emergency, I'll give an example, AIMS emergency, we had an ICMR project on that. The admission rate was only 16%, much lower compared to for all illnesses, not respiratory infection. So the chances that an older person with a serious illness deciding to go to hospital, getting admitted, is only 1 in 6. So what happened to the rest? The family was convinced that take this prescription, give at home, kya rakha hai, what's there, what's left, and you can manage at home. So kind of a bit of a nudging that go home on the part of health system, because there is always a competition between the young adult or younger patient with infection and a older patient with infection. So that's the institutional issue, that there is an hesitation to admit the older person, not looking so bad. And the social factor. Social factor is very important, that who is going to pay for the care, or who is going to take to hospital, who will do the night duty. So there is a family hesitation that if you can manage at home, it's much better than staying in hospital. So that's my experience of all these decades, that unless there is a very convincing reason in the heart of the son or daughter, or the son-in-law, daughter-in-law, that let's go and stay in hospital, it's likely that the patient will be treated at home. And also our making the right choice of antibiotic, etc., are somehow not very convincing in our general practitioners and internists in the private sector, that what sort of antibiotic should be given, injectable or not. And when we teach infection in older people, we will say that give an antibiotic, broad spectrum, if there is a suspected infection. But that doesn't happen, because it's not always considered that this may be a serious life-threatening situation, let's intervene rather strategically and do the right treatment. There's some comment on the death rates. We did some publication on pneumonia in hospital setting. About 35% of older people die when admitted with pneumonia, compared to about 15% in young adults. So there is a disproportionate death in older adults when it comes to pneumonia-related death. But in community, if you look at the whole scenario, all are not as serious to be in hospital. So obviously, 20% rate appears quite logical and quite adequate. I think I have answered all the questions that you asked.
Next, I'd like to ask question to Dr. Nivedita. The information presented today was from a CDC AIMS ICMR research platform. We all agree that surveillance is of utmost importance, and before rolling out a vaccination program, more so. So it provides us justification initially, and then also helps evaluate the vaccines. In this context, what are the current national level surveillance platforms for influenza, and how can the current influenza surveillance platforms be reoriented to better inform vaccination policy for the elderly? Thank you.
Thank you very much for the question. And I thank the organizers for inviting me for this esteemed panel discussion. So the data that we saw in the morning, it's a very valuable data set because I've been attending NTAGI meetings, and the decision-making process, whatever it involves for taking a policy decision on whether a vaccine should be introduced into the program or not, many of the aspects have been covered in the study. As we see that it presents the burden of infection, then also you have done cost effectiveness studies, and you have kind of pinpointed what would be the opportune age at which vaccination has to be given. So I think this is a very valuable data for the program, and particularly for the NTAGI to make an evidence-based decision. And supporting onto your whatever data the INSPIRE study has generated. So we at ICMR run a pan-India ILI SARI surveillance network, and we look at the trends of various viruses that are prevailing, and it is we look at 3 viruses: influenza, and definitely influenza A and B and their subtypes, COVID-19, and as well as RSV now. So this surveillance captures the trends of prevailing viruses across these 30 sites in India, which are geographically distributed. And we also see in our data, like when I look at my data, then what we see is that the proportion of SARI that we see in under 5 is actually 68, and when we break it down to less than 1 year, then it is 90%. So this is in the younger age group, but when I talk about the elderly, particularly above 60 years, then 50% of the infections that we saw, respiratory infections, were SARI in this age group. And when we move on to age groups above 80 years, then it increases to 68%. So what I'm trying to say, that a significant burden of respiratory infection culminates into serious infection, that is SARI. In at least half of the patients would convert to SARI if you look at above 60 years age group. So I think vaccination in this age group is a very, very prudent step that we should advocate, along with pneumococcal vaccine based on data. And to the best of my knowledge, this is the system, surveillance system that ICMR has established. Is whatever INSPIRE definitely has been there before the ICMR system, and we actually talked so that there's no overlap and we complement each other's data. So I think both these surveillance systems are working well, and definitely we can, since ours is a pan-India surveillance network supported by Government of India and a sustainable system, it would be prudent, like I was talking to Dr. Chadda in the morning, that we can brainstorm with all the distinguished audience and experts in this room and show them, and also take their advice on how to tweak our system to generate more data, which would be required for policy making. But as of now, I feel that this INSPIRE study, whatever you have generated, is a very valuable piece of information for at least decision making for the government in the NTAGI. And Dr. Indrani can supplement me more if she finds any gap. But to the best of my knowledge, this is a very good starting point.
Thank you. The next question is to Dr. Kaul. So Dr. Kaul, as a former NTAGI member and as an advocate of influenza vaccination, how would you rate the quality of the study that Dr. Anand presented today? And based on your experiences as a clinician and the evidence presented and views expressed today, do you think that the current national guidelines on putting elderly in the desirable category for vaccination need a rethink?
Thank you, Dr. Anand and team for having me as a part of this panel discussion. As a part of the NTAGI, I think I must first put up a disclaimer that whatever happens in the NTAGI, we are sworn to confidentiality for a prolonged period. So whatever I would be saying does not have to do anything with the NTAGI. But as a general statement, NTAGI is a recommendatory body. And whatever we discuss in the NTAGI and what we used to discuss in the NTAGI is basically a recommendation for the government to think on in terms of implementation, in terms of a policy. Because the money is with the government. The ministry has to decide as to whether they have to implement our recommendations as a part of the program or not. Talking of influenza vaccination in children or in adults are not a part of the universal immunization program of the country, A. B, adult vaccination as a concept in the country has not taken root at all. So the only adult vaccination which we are talking about in India is about COVID vaccine, which was driven by a strong political will. To now probably we're talking about the HPV vaccine. Otherwise, beyond these two, we don't have a real concept of adult vaccination in the country, as is available in the Western countries. So yes, there are vaccination campaigns which are run by individual physicians or physician bodies. So whatever happens in India is on the basis of the individual effort of a physician. Because a physician, for example, treating a patient of chronic obstructive lung disease, believes that this is a patient who must have received an influenza vaccine or a pneumococcal vaccine based on the timings whenever they must. So they derive their recommendation or their prescription from the international guidelines. And using those international guidelines, they give these patients the vaccines. There is a recommendation by the government of India for treating patients, for giving vaccination to certain high risk groups, and that does include people with comorbid illnesses. But as such, since it's not a part of the program, and as Dr. Anand said, that cost becomes an impediment, and cost would come down significantly if it is taken up as a part of the program. So yes, there is a distinct compelling evidence that was presented in the INSPIRE study in the morning, that one group where we must think of moving from the desirable to the recommendation would be probably the elderly or the older adults, as Dr. Dave would like to name them. I must also point out in this data that I looked at the self-reported comorbidities, and they range from anywhere from 50 to around 85%. So that is actually strengthening what Dr. Anand was saying in the morning, that most of them have some degree of comorbidity anyway. So they would be anyway falling in that recommendation clause anyway. But as age being the single factor for putting them in the recommendation clause, this data suggests that we must give it a serious consideration.
Thank you, Dr. Kaul. Dr. They also referred to sort of an ethical issue of elderly being sidetracked for admission because system constraints are there. And so this is a question to Dr. Indrani Gupta. Whenever we do an economic evaluation of elderly related programs, we invariably underestimate the economic impact because they don't have too many years to live. If the same 84,000 deaths occur in a younger age group, they will contribute to higher years of life lost, right? If they die later in the life, their economic loss is much less. So inherently, any intervention aimed at elderly does not sound as cost effective as such childhood intervention. So does that mean that we should pay less emphasis on interventions aimed at childhood, at elderly, or purely for ethical reasons. We should not go too much into economics of this and go more into ethics of it and do something about it. I think because you're not.
Yeah, thank you very much for inviting me for this really enlightening session. I went through your PPT, I couldn't be here in the morning. As an economist, the main question that you're really asking me is whether economic evaluation techniques are appropriate to kind of understand vaccination for the elderly, whatever that vaccination is. Now, my quick answer is that economic evaluation, we shouldn't summarily dismiss economic evaluation because they have their place in resource allocation. So when resources are scarce, you obviously need economic evaluation. The question is not whether your incremental cost effectiveness ratio looks good because you're comparing it with no vaccination. The question is when resources are scarce and you go down a list of interventions for the health sector, where does the vaccination for the elderly come in that list? And are there other superior interventions that are more worthwhile in the economic sense? So to that extent, of course, we know all the shortcomings of evaluating vaccination among the elderly. It is all about how you value life. So the valuation, there has been so much of literature on valuing life and how that should be done. That you can have a huge whole day session on that. But the main issue is that if you are going to be able to estimate the cost and consequences of the vaccination program among the elderly, maybe you will not do that badly. The problem is that we don't take care of all the consequences and costs of vaccination program among elderly or any other group because it's very difficult to actually assess. So there are three things, for instance, the perspective. So we say we are taking the societal perspective when we do our calculations, but actually we are not able to fully take into account the societal perspective as well because there are all kinds of other issues. For instance, the contribution of the elderly to the household economy, caregiving, the informal sector, all those things are not evaluated. I mean, if you are going to employ somebody else to look after your children rather than the elderly parents at the house, you would have to pay a market price. So all those things are not evaluated. There are also evaluations of individual from an individual perspective and a societal perspective. So, in economics, we always say it's very difficult to come to a consensus. Who do you really value most? Now we say, okay, we have taken a societal perspective. That's a very summary way of dealing with this issue of individual versus community valuation of a particular thing. There is the other question, last question I want to deal with here, because there are other questions I know, is the distributional impact of the vaccination program across groups. Now, is equity a factor that we at all consider? Now, I have been also in the INTAGI, and I agree with Professor Kaul that we don't discuss any of the matters. But one thing that came up in even the HTA that I was part of is that we say that we are taking into account equity, but we actually never do in all our empirical analysis. So if equity is a big bullet, then yes, the ethical considerations come in, and we say we value this particular group of people, and from an equity perspective, therefore, the distribution of resources should be such that they garner a fair share of the total scarce resources. So I will stop here by just saying that there can be other considerations. Though your vaccination is cost effective compared to no vaccination, when you rank all your interventions, it may not look very good because there are obviously the young ones and the numbers are on their side. In that case, we need to bring in distributional issues, equity, perspective, etc. into the picture, which are all in the area of ethics. So I think that is, hopefully that answers your question.
Yeah, ma'am, thank you. A very interesting perspective, but please carry on.
So the next question is to Dr. Siddharth Shah. So what is the global situation and experience on influenza vaccination among the elderly in developed and developing countries? And what can India really learn from these country experiences in planning their vaccination strategy for the elderly?
Thank you, ma'am, for the question. And again, before I start answering the question, let me also give a disclaimer. As Dr. Mandeep brought Dr. Anand into influenza, Dr. Anand brought me into influenza. He connected me to CDC office, and then eventually I've spent my last 10 years here in this program. So thank you for giving this opportunity and this wonderful work that we have been able to do together for the INSPIRE study that the results were disseminated today. So yes, globally, if we look, well, WHO has made its recommendations quite clear. Older adults are among the priority groups for which WHO recommends seasonal influenza vaccination. If we go by countries, there is like the joint reporting form that every country reports, and that data is published. It takes some time to analyze that data and publish. So the most recent analysis that was done for 2018 data and published in 2021, that showed that of the 194 countries that reported data into that JRF, 114 countries have vaccine policy for older adults. And most of them are actually in the developed and or large economies. Most of the, in terms of regions, it's the African region and the Southeast Asian region where we are lagging behind. But most of the other regions have moved ahead and used influenza vaccine as a tool. If we go by country experience, again, we all are familiar with the Advisory Committee on Immunization Practices of US. So they recommend vaccine 6 months old, everyone is eligible if there is no contraindication. But for 65 and years older, they have a specific recommendations and prioritizing them with the high dose vaccines, which also Dr. Chadda referred, because of the challenges in getting good immune response in older adults. Higher dose or adjuvanted vaccines are being recommended in US. The ECDC, which is the body for the European Union, they in their most recent advisory on influenza vaccine actually accorded highest priority to older adults. They have changed their recommendation. They say that all recommendations stand like this, but older adults are the highest priority, and then persons with some comorbidity. So they have also re-accorded the kind of reprioritized the vaccine for the older adults. And coming to the question of how we can have learned from these experiences. So CDC has been collaborating with Task Force for Global Health to support vaccine introduction in countries. This is both a technical support and in countries with low, particularly low and middle income countries, if they need some, initial vaccine donation to kickstart the program, so that vaccine donation has been arranged. So that's called PV, Partnership for Influenza Vaccine Introduction. It's something of a similar model as Gavi, but on a more focused on influenza vaccine. So over 30 countries have been supported, and as I am also providing support to the neighboring country of Bhutan. So I can share that in Bhutan is also one of the PV beneficiary, where we have been providing vaccine introduction support. We helped the countries to develop guidelines, prepare micro plans, and train how to train or the training materials for the healthcare workers. So those kind of support CDC provides, and this PV experience is generating new evidence. That experience and those papers are being written. Some of these papers will likely come in a upcoming special issue on vaccine. So that will be a special issue. But Bhutan, although is a small country with a small population, but has a very difficult terrain. So, but it used its vaccine program. It was introduced right before the pandemic. In fact, 2018-19, we were rolling out influenza vaccine in the country, and they used that program, that macro planning, to roll out their COVID vaccination program. So it came in news that how this country could achieve its first dose coverage in record time, and many of us would also think that this is a small country, it's a small population, but it's with very difficult terrain. Connectivity is a big challenge. There is only one airport that
has its like from international route connectivity, there is only one airport, which is also not always accessible around the year. But still, they managed to do all that vaccination because they had some influenza vaccination program, which is not just for. There is always the routine immunization program, but also a program for vaccinating the older adults. So together they use that experience and then used it for their pandemic response when they did the first dose of vaccination. So I'll pause you and thank you.
Thank you, Siddhartha. So I think all of you are saying that there is a case for vaccination, but there is also an other angle that most professional bodies, whether it is pulmonology or geriatrics, they all recommend vaccination. Yet associations recommend, but doctors don't recommend. Because we have seen and we have done surveys that no physician actually recommends influenza vaccination to elderly, even though their associations have made such recommendations. There is something which stopping people from clinicians, and it's not just obviously a cost consideration. Even richer people, we don't really have a good coverage of influenza vaccination among higher socioeconomic status who can afford to purchase the vaccine. So what is it that, are the physicians not convinced that it is useful? While we are saying that we should roll out a program, even in a clinical setting, its recommendation is not really that good in the Indian context. So what is it that is stopping clinicians from recommending it to affording patients who can afford it? So, Dr. Dev first, and maybe Dr. Paul also wants to add on that. Yeah.
The challenge is that adult vaccination is not a very popular entity in our imagination. I spent 4 decades in AIMS, and if I take out COVID vaccination, which was virtually a passport to do anything, I just took back a meningitis vaccine in 1985 or 86 when there was an epidemic in Delhi. So I have now not even taken hepatitis B vaccination despite in the health system, or even rabies vaccination. No dog has ever bitten me. So actually, adult vaccination is not a very popular thing, whereas in the universal vaccination is that every young mother would be thinking how to complete that vaccination, very proudly demonstrating that all the vaccines for my kid is completed, etc., etc. That doesn't happen. So from that point of view, just think of it, unless the government put all its might for the COVID vaccination, would have been possible with our usual mindset, not even 10%. So we have got a resistance in our mind that something which is a preventive treatment, doubtful value plus minus, even I also always feel that in this influenza vaccine business, the confusion between northern hemisphere, southern hemisphere, what is there in Delhi and what is there in Chennai, there is quite a bit of a confusion regarding at what point of time you give the vaccine, October, November, or January, February, or Dr. Anand's data tells us that the vaccine maximum amount of influenza occurs in July, August. In some of his conversation, he tells that July, August, there is a surge in vaccination, so it should be given in June or something. So for the physician, influenza vaccination is not a clear-cut recommendation. I mean, the associations may say something, but while writing the prescription, this comes in. Practically thinking, I tried to do some influenza vaccination and pneumonia vaccination program in geriatric medicine as a part of NPHC. Sometime in 2014, there was an instruction from PMO that you develop a new program or a advanced program for 75 plus within NPHC, and we had a big meeting in ministry, so that we thought what 10 things we can do. One of them was we give influenza and pneumococcal vaccine to all 75 plus. Somehow that did not get into the main framework, but I had it in mind that this is probably accepted. So in NPHC, every regional center gets about 20 lakh rupees for drugs and chemicals and all investigation. And in AIMS, the head of the department has enormous power in a clinical department to get any drug available anywhere on the earth to the patient by writing that a poor patient and getting all the investigation exempted. So I did have that 20 lakh rupees to do something. So I thought I'll do that, a vaccination program. till I retired, I use that money, 20 lakh rupees every year to buy vaccine and give it. After a while, I found that that has become a headache for me because my residents will not prescribe vaccination. It is only my headache that every day I will go and before as the residents come in, I go and tell, please write the vaccines they are getting, they will expire by March. And so, and after I retired, the issue also died on a natural death because of COVID program, etc., etc. Vaccination is over. So what I want to emphasize is that giving influenza vaccine as a part of program in a health system is not an easy job. Unless you kind of do it like say this polio vaccination, that you put the whole might of the state, and then polio is a much serious and much is a much greater issue from the health system than probably influenza. So when it comes to individual prescription, say I as an enlightened physician, I think myself as an enlightened physician, I will write to every 75 plus or 65 plus or every patient who comes to me who can afford it, because CGHS doesn't give vaccine. So the most of the Delhi population who are retired people from CGHS, they from central government will not get it. So I have to tell them that, convince that it's not much, 700 rupees, and the other one is about 1200, 1300 rupees. So you can afford it. So it is kind of depends on the individual physician's conviction himself or herself to prescribe it and follow it up. Of all the patients I would have prescribed both vaccines, about 50% remember to reinforce it on the next visit. The time ho gaya, likh dijiye. So it's a kind of there is no vaccine culture in our country. I should make a very that strong statement. But then probably adult vaccination is not a very popular concept in most part of the world. I stop here.
Thank you, sir. I think Dr. Praveen wants to add.
Yeah, I think I would draw your attention to two studies that we conducted some time back. One was looking at the healthcare workers, and we recruited around 1,400 healthcare workers and wanted to find out what is the knowledge, attitudes, and practice of theirs regarding influenza vaccine. And despite the fact that most of them thought that influenza is a potentially dangerous disease, and nearly everybody knew that there is a vaccine available against it, only 4.4% of the total 1,400 were actually vaccinated against, I'm talking about healthcare workers, were vaccinated against influenza. And the reasons they put forth was that they were not sure about the safety of the vaccine. They were not sure about the efficacy of the vaccine. They said that the healthcare care system is too fast to jump onto anything that is not proven to be very, very effective. So there was a disconnect between what they knew, their knowledge, and what they practiced. And then in India specifically, as Dr. Day said, that there is sometimes a confusion whether to use the northern hemisphere or the southern hemisphere vaccine, which makes it difficult for the policy planners to roll out a uniform policy across the country. Cost is an impediment. Many people say that cost is an impediment, but there is a paradox also as well. I'm sure that many of you know that the Serum Institute developed a univalent vaccine at the time of pandemic influenza. So that pandemic vaccine was given, they had to actually discard about 1 million doses because there were no takers, and that is sad. Because unfortunately, people are not keen to take it. And then I think, in my opinion, the biggest impediment to rolling out a vaccination program is the hesitancy on part of the healthcare providers. Because unless you convince them that it needs to be really given to the patients under their care, they will not give it. Case in point, we recruited 1,000 pregnant females and wanted to test as to how many of them have been vaccinated against influenza at a time once they were pregnant during an influenza season. None of them were vaccinated of the 1,000. None of them. We asked their obstetricians treating them. Of the 91 obstetricians, only 8 were themselves vaccinated against influenza. Now contrast this with another 2 vaccinations, hepatitis B and tetanus, 100% uptake. So where does the buck stop? Buck stops with the healthcare provider. Unless you prescribe, nobody is going to take it. That's where I stop with that question.
Thank you, Dr. Kaul. That was, I think, you hit the nail on the head. But coming back to now, Dr. Indrani, you said that there are competing causes, obviously. This is one among the multitude of interventions that government considers. But today also we are seeing that India is becoming third largest, 5 trillion big developed country. There is an increasing in the cake also. While the paces are small, the government is also trying to increase the cake that is available to be split between different interventions. So is there an interest in the government, in your estimation, that these kind of interventions will also find a place in its armament because it wants to spend more on health? Does that provide us an entry point to push for a vaccination like this?
Sorry, we may be becoming the third largest or sometimes the second largest, but if you look at what we did with the health budget, you'll know that we haven't really prioritized health even now. We had 3 rounds of COVID, and our budget, we do a lot of budget work in IIG, stayed just the same, or in fact, in some places where they shouldn't have gone down, allocations have actually gone down, like NHL. Now, in that background, I'm slightly pessimistic in the sense that all of this, the providers, this health system not functioning, all of that has also to do with resource allocation, how much money you put into the health sector in your own elaborate public health facilities that we have created. There is so too little to go around, basically. So everybody is stretched. We have put every onus of the primary care on ASHAs, at pittance that they get. So my take on this is that unless the government actually, forget G20 or 21 now with Africa, all of that, basically sit down and figure out how to increase allocations to the health sector. Otherwise, none of this is going to happen. We may still adopt a vaccination. The reasons would be outside of economics, clearly. It has to be a political and governance, some other reason why we're doing it, which is all right. I'm not putting that down. But my own sense is that all our vaccination programs, all our health interventions that we adopt with this little, money is going to be, we will operate at a very low quality effectiveness level. And that is going to boomerang back on the health of the people in this country. So you will have ineffective or low quality vaccination programs, outreach would not be as much, all of those things will happen. So the quick answer is, yes, we can still see adoption happening because that is not really something that is being, cost effectiveness analysis sounds very good, but we also know that our decisions are not generally based on cost effectiveness. So I have moved away from cost effectiveness analysis because it doesn't really matter what we calculate there. Main aim of the government should be to increase health allocations, not from 1.3 to 1.4, but 1.3 to about 2.5 to 3, if we want to see better outcomes in the health sector.
Coming to the next question, we go back to vaccines and go back to Siddhartha. So currently we know that the available vaccines have several shortcomings. They may vary in terms of effectiveness, and as somebody pointed out, when should the vaccines be given, etc. And the need for annual doses is also is a problem. So there were attempts, there have been attempts for developing a universal vaccine. So what are the global advances, recent global advances towards this effort? And in the Indian context, would that really be useful?
So, yes, there are, in fact, with the COVID, we also saw many new vaccine technologies being used and developed. These were in pipeline for almost over a decade, but COVID kind of accelerated the development and brought those vaccines quickly for the population. So that's been a remarkable achievement from, at the global level. But coming back to the influenza vaccine, so first I will talk about the efficacy briefly. So when we say it's a low efficacy, but we have to also understand that this is actually a multivalent vaccine in the sense that it has just not against one virus. There are multiple, there are at least 4 antigens. The quadrivalent have targets for 4 viruses. So even though overall efficacy may be lower, but from season to season, we have seen that there are other, for some other variants, their efficacy is actually quite high. It can be as high as 60 to 70%. And that's against infection, but against disease modifying or its ability to reduce hospitalization is the efficacy will be much higher. So that is, we need to take into account that this influenza has a reasonably good efficacy. Yes, among older adults, it's a challenge because of the immunosuppressants and this thing. So there are, as you also alluded to that, vaccines with high dose or adjuvanted or even recombinant influenza vaccine dose. There the antigen quantity are much more. Compared to say standard dose, which has around 15 microgram per this thing, the recombinant one has 45 microgram per virus, whereas the high dose has around 60 micrograms. So it's substantially higher than this thing. So it, of course, the adjuvanted has almost the same cost, but there is an adjuvant. And doing a vaccine studies, particularly efficacy studies among older adults is a bit difficult. One is that, even the detection of virus among older adults is a challenge. So in terms of detecting an efficacy, in terms of preventing infection, those are kind of challenges. But only few countries have introduced these newer vaccines, the high dose, and the US is one of them, and they have done some studies. There are studies published which looked at over several seasons and the relative efficacy of say high dose vaccine compared to the standard dose vaccine has ranged from season to season. The overall efficacy ranged from say 9% relative efficacy. So from 9% to as much as 23, 24%. So those higher dose vaccines are being more and more widely used. In fact, ACIP specifically recommends these high dose vaccines for older adults. And there are some few other countries, particularly after ECDC has also started along those same lines. So those are vaccines that definitely as a program India might consider. As far as the newer technologies, there are also in pipeline some vaccine which has also SARS-CoV, but it will take some time. There are some regulatory issues and how this efficacy will be, that would yet to be seen. So those vaccines may take still time, but we still have enough good vaccines in our armament which we can deploy now and take full advantage of it. Thank you.
Thank you.
Thank you. Now I come to you, Dr. Kaul. I think we did present evidence of cost effectiveness, but Dr. Indrani Gupta feels that the cost effectiveness will not work. So what will work? In the sense that what other evidence is needed? One can say that evidence itself does not work. But we are all academicians. Our job is to generate evidence. Others are for others to do. So what more evidence would you like this group to generate to convince people?
I think if you import evidence from what is available internationally, there is robust bit of evidence for using influenza vaccine across board in various high risk groups, including those of the older adults. However, I do not go into the detailed analysis of the data presented in the morning. I, being an editor of a journal, know that you don't have to cursorily look at the data. You have to go incisively at the data and then probably talk about the goods and the bads of any data set. But that said, there is clearly a compelling evidence from the data that you put forth in the morning. However, there are certain things that I would have liked in addition. For example, what are the non-respiratory benefits that you're looking at? I mean, you yourself said that influenza has been associated with development of myocardial infarction or strokes, and those who have received an influenza vaccine are so much lower at a risk for developing an MI or a myocardial or a stroke, or even diabetes related complications. So Yes, I mean, those can be things that can be looked at. Also, I must say that sometime back we looked at chronic obstructive lung disease, and Siddharth was a part of that paper, and as was Dr. Chadda, that we found that in chronic obstructive lung disease, which is very frequent in the country, uh, there are various stages, and once we looked at around 200 patients to find out how many of them survive after they come to the hospital for an acute exacerbation, 40% of them are dead at 2 years. So that is a mammoth proportion. So we wanted to find out, does influenza contribute to this influenza, this acute exacerbation? Of the 500 patients that we recruited, 50 had a reason rooted in influenza infection. So there is a strong case, and most of these are older adults. COPD patients, most of them are older. So yes, there are other things that could be coupled with your data that you presented that look at what are the various subgroups that you can look at non-respiratory benefits. And also vaccine effectiveness studies are unfortunately not available in the country. We don't have, apart from some data from our center, which looks at specifically on the influenza in hospitalized networks and as a part of the GIHSN group, which we are been fortunate to be a part of. But vaccine effectiveness studies as a whole in the country are not very many there. And there is probably one study from a vaccine efficacy study that came, I think, very recently from your group. But beyond that, there are hardly any data. India is a continent. India is not a country. Please understand that. And there is so much of geographic diversity, cultural diversity. So we need to have data. I mean, even in surveillance, when we talk of surveillance, we have data from Bangalore. We not have a data which is from an area which is 50 kilometers away from Bangalore. So that actually impedes the universal application of the data. I mean, people say that we have no data from our area. We talk of NH and SH. We have data from some areas, but we have no data, absolutely no data from the other areas. Those are the things that probably Dr. Nivedita talked about, that we are panning it across the country so that we have more and more data available, which can then probably be extrapolated to the whole of the country. So yes, there are very many data inadequacies that we have to grapple with. And I'm sure that as we move around, we will have, and as a country, I mean, we did just publish this August a paper on predictors of various predictors of severe outcomes of influenza. And one of the biggest predictor was living in a lower and middle income country. Anybody living in an LMIC is at least 7-fold at risk for ICU admission because of SARI, compared to somebody living in the higher, whatever the reason. I'm not going to the reasons for that. So there is a distinct case, and we were talking about uptakes of influenza. It also varies from area to area. I mean, I think that we did a study last year in Kerala, post-COVID. Healthcare workers, 70% was the uptake of influenza vaccine. But once we removed the condition of it being as a part of your employment, the vaccination uptake came down to 36%. In the top north of the country, in Kashmir, our vaccination uptake is definitely higher than what you reported in this study. So those are various facets that we have to look at and probably intervene.
Our last question goes to Nivedita. See, ICMR has really played a very crucial role in generating the evidence that was presented today. Our question is, can anybody in this group help out or assist ICMR in this regards, in the regard of protecting our elderly?
Thank you for the question. So I just wanted to highlight 2-3 things based on our experience of doing several vaccine hesitancy studies during the COVID pandemic. So what we saw is that initially when the vaccine was introduced in 2021 January, there was hesitancy even among healthcare workers and high-risk groups. But when Delta wave came and there were so many deaths, then suddenly the vaccine hesitancy disappeared to reappear again after the Omicron wave when the deaths decreased. So what I'm trying to say is that death is the ultimate fear among people which really like instigates them to take the vaccine. And second, of course, is the severity of infection in terms of whether I get admitted to ICU, how many days I was on ventilator, how many days I was in the hospital, all those kind of things. But I think ultimate fear is death, followed by severity of infection. So what I'm trying to say is that we are talking a lot about like improving or removing vaccine hesitancy. But 2, 3 things I think we can plan to do. Number one is that we regularly disseminate data on what are the numbers of deaths which are caused due to influenza in elderly, if we really want to make a strong case. Because even if we push it at the level of NTAGI or the policy makers, if the uptake among the people or advice from the healthcare workers doesn't go, then actually the program fails, as the esteemed panelists have already pointed out. So I guess appropriate and accurate dissemination in terms of what are the number of deaths, what is the severity of infection, what is the clinical course of illness of influenza among elderly is something which we really need to sit, brainstorm and see that how this data can be generated effectively through all our sites and can be disseminated regularly so that people understand that vaccine is required, and if we would have taken vaccine, then at least a proportion of deaths could have been averted. That's one thing that I feel. The other thing that I was thinking was that now the vaccine hesitancy, we are talking at 2 levels. One is at the healthcare level, one is at the community level. Now, healthcare level, I feel that the major problem with influenza vaccine is even the healthcare workers don't know whether we have to give northern hemisphere, southern hemisphere, when we like our the composition of our circulating strains is matching with northern hemisphere. We don't have that vaccine available at that point in time. It comes a couple of months later. So these kind of things, then they start arguing that what is the use of giving the vaccine, even the healthcare workers. So I think we really need to sit with them and kind of generate data that even if the vaccine, appropriate vaccine may not be available at that point in time, still certain proportion of mortality is averted. We don't have that robust data. And now the era is that even if we draw conclusions from Western data or any other country's data, people in India don't accept it. Like even our experts, and when we are sitting in different panels, we ask for data which is generated in the country. So I think we really need to structurally plan our surveillance systems to generate this kind of data so that we can make a case that, look, this is happening. Even with whatever vaccine we have at any point in time, we are able to avert these many deaths. And the second hesitancy is at the level of the community. And definitely for that, if we are able to advocate data related to death and severity, that puts a case. And even if it is expensive, some people, even the middle class people, would go and take the vaccine if we put our case very strongly. So I think we really need to brainstorm on that aspect very, very strongly. That's what I feel about it. And the last piece that I wanted to say was that now we have an excellent system, the Inspire system that you have set in. And there are certain hospitals where these VRDLs and these labs are located. Can we think of doing strong advocacy programs within these setups and see whether we are able to improve or remove the vaccine hesitancy, at least at these sites? So if we could build a separate arm of this study, I'm not aware whether you are doing it or not, but building advocacy tools and seeing whether we are able to impact vaccine hesitancy through this study as a pilot, and then taking those tools to a much larger level to see whether we can really make an impact at a national level.
Thank you, Dr. Nived. I will respond to two of your issues. One, I am very happy that you put data at the center of everything. I think VRDL is also generating data, cause of death data. So I think that's the way to go ahead. We think we all support that data should be more available. But you would be glad to know that this Inspires also looks at healthcare worker cohort to see how many of them developed influenza, how many have been vaccinated, and will plan an intervention subsequently. at least among these 10 sites, 10 to 12 sites that we are taking, participating hospitals, there will be an intervention both to take vaccine as well as to recommend vaccine. And we'll see how much it results in the change. So definitely we would be interested in, we would be doing that in subsequent years, in next couple of years. So thank you. I think we had a very good panel and I think very honest and frank panel. So does the audience have any questions to the panel before we close this? Nothing from the audience. Does the panelists want to say something as their last words before? Then you can.
Actually, I missed answering the question that was on the seasonality and this thing. And thanks for again raising this issue of seasonality and the timing of vaccination. So, yes, I mean, a decade back, that was the advice that was given by WHO in its biannual vaccination, that for the Northern Hemisphere, there is a Northern Hemisphere vaccine and there is a Southern Hemisphere vaccine, then there is a for the Southern Hemisphere. But then, again, it was led by NIV. Dr. Chadha was one of the main investigator for that study, which showed that in the tropics and in countries like ours, the influenza circulates around the years, but the surge is during the monsoon season. And depending on the parts where the monsoon arrives, there will be surge. Then there is a surge that and then some of the areas in India, which are particularly Srinagar, we have seen there is a winter peak. And then even some northern parts, they will have another peak around winter. So that is, and then globally also we saw this evidence that the influenza has been circulating in tropics around the year. And now the current WHO recommendation is that for tropics and subtropical region, use the most recent formulation. Because what is the very interesting thing is that there are countries in Northern Hemisphere, but this vaccine timing is much suited if they use the Southern Hemisphere vaccine. Then there are countries in the Southern Hemisphere, they are still in the tropic and subtropical region, but they are in the Southern Hemisphere. But their seasonality is such that for them, the Northern Hemisphere vaccine is much more timely. So for the tropic and subtropical region, this, using that Northern Hemisphere and the Southern Hemisphere vaccine is not very useful. It is for them, they have to see what is their seasonality and what is the most recent formulation of vaccine. And in that context, I think this ICMR's Pan-India initiative is a great one, because that provides disaggregated data at the state level. At least the states will have, and as Dr. Kaul said, India is in itself is a continent, and in every state is like a country. So with more local data, states can now decide on what should be their right timing of vaccine, and then accordingly, which is the recent formulation. Doesn't matter whether it's Northern Hemisphere or the Southern Hemisphere, which is the most recent formulation of vaccine, and that should be the advice. Thank you.
Thank you, Siddhartha, for clarifying. Any other comments from the panelists?
Just one, building on what Dr. Siddhartha said, that this Northern Hemisphere, Southern Hemisphere, 22 November, we published a small letter in the Lancet saying that what he said, that influenza doesn't respect the geographical equator. That is the 0-degree latitude. So we talked about a new influenza equator, which is located somewhere at 30-degree north latitude. That is where, anything upwards of that is northwards of this 30-degree latitude is mostly respecting the Northern Hemispherical seasonality. Anything south of it probably mostly respects the Southern Hemispherical seasonality. So India, despite its geographical location in the Northern Hemisphere, doesn't respect the NHSH seasonality. So that's why we talked about the influenza equator, which is located somewhere around 30-degree latitude. And that seems to be respected by even big countries, large landmass countries like Brazil and China. That's it. Just a moment.
Thank you.
What's from your side?
He's covered.
Okay, thank you. Thank you, everybody. Thank you, our esteemed panelists, for a very frank discussion. Thank you for the audience. I would now request the team to felicitate the panelists.
Requesting all to check out rooms if you have not done till now. And we are going to assemble after lunch again because there's Inspires has another session. Okay. So